Go ahead, Jeff.
All right, I'm gonna try to share my screen here. You guys seeing that okay?
Yes.
Okay, great. All right, well, thanks everyone for having us. I'm gonna present the accumulation of a QI project that's been quite some time in the making and has at various points involved about half of our ID fellowship cohort. These are very basic and very preliminary findings, so we'll only be talking for about 10 minutes, but if there are other outcomes of interest that come to mind from a provider perspective, please just let us know. So the project was originally conceived and designed with general QI questions in mind. And in particular, we wanted to get a sense of what outcomes we're seeing within the anal dysplasia screening process among MSM in clinic. And then secondly, to determine where in the care cascade patients were falling through the cracks. So we'd know where to focus on for things like further investigation, provider education, and targeted interventions. And so we focused on MSM in particular, given the increased prevalence of anal SIL and anal cancer in HIV positive MSM populations and our prominent MSM population at Bartlett. And so it helps to be clear about what exactly the referral process is. And so as I go through our methodology for the analysis, this will be framed around the care cascade as we currently have it established. And so current guidance is MSM HIV positive patients to undergo anal pap smear annually, and age cutoff is a little non-specific depending on which guidelines you look at. So we pulled the numbers and dates of in-person clinical provider encounters for adult HIV positive MSM patients. They were identified as male by gender identity as assigned in EPIC, since this was the closest we could get to a patient-derived identifier, and then identified as MSM by cross-referencing these MRNs with sociodemographic data that was available in the CareWare database. And the study period that we looked at was between October 2019 and April 2021. These dates are a little strange when you first look at them because they do encompass the first year of the COVID pandemic when clinic processes were highly disrupted. But these dates were originally selected logistically because referrals for endoscopy were limited prior to October of 2019, and then again unavailable from roughly March until August of 2020 due to COVID. So October 2019 through February 2020, and then August 2020 through April 2021 provided roughly a 12-month period where endoscopy was available and patients were being seen for in-person appointments to receive their screening anal PAPs. And so if the PAP is normal, the patient continues on to be screened annually. However, if it's abnormal, so it contains ascus, LSIL, or HSIL, the patient should have a referral placed in EPIC by their provider for high-resolution endoscopy or HRA. And anal pap smears and HRA pathology results and placement of the referral for HRA were determined by manual chart review. And this includes outside pathology reports that were available and the wide range of ways a provider could refer a patient for HRA over the course of the study period, which includes sometimes sending them to general surgery, sometimes to colorectal surgery, seeing Dr. Fang before she left the Hopkins system, and Dr. Grasso, who's outside of the Hopkins system, and then more recently with establishment of the HRA clinic at Green Spring. And so this is how these numbers ended up breaking down. We had 779 MSM patients seen for at least one in-person visit. The average within the patient cohort was actually about 3 to 4 visits during the study period. But only 190 of these patients, or 24% of the total number of patients with in-person appointments, actually received an anal pap smear. And breaking that down by result, in green are patients with a normal pap. The thin kind of yellowish orangish bar is patients with PAPs that were indeterminate and needed to be repeated. And then 40% of all patients who had PAPs done were abnormal, warranting referral for HRA. So of those 87 abnormal PAPs, 63 or about 72% of them had referrals placed in their chart, but only 26% of those with abnormal PAPs actually received an HRA during the study period. So a quarter of patients who had abnormal PAPs and about a third of the patients who had active referrals for HRA were actually able to get the procedure completed. And if we define appropriate navigation, kind of quote unquote, of the anal dysplasia cascade as either getting an annual PAP that results as normal, which is true for about 97 patients, or completing a referral and HRA for those with an abnormal PAP, which is 23 patients. We had a total of 120 or 15% of those eligible for the screening processes in general who appropriately navigated the anal dysplasia care cascade. So clearly some room for improvement with a couple of different angles, most notably in actually getting the screening anal PAP done, which is the biggest step off, but then also in scheduling and completing HRA referrals after they're placed in the chart. And the other part we were interested in is whether this affected case detection rates for HSIL or anal cancer, and if so, whether those trends could potentially impact how the dysplasia care cascade is structured. So for example, some providers have traditionally preferred to continue with annual PAP screening for ASCUS or LSIL because of the perceived logistical difficulties with the HRA referral process. So would it be reasonable to incorporate that into the care cascade? Or do we have evidence that all patients
Chelsea, I think we lost you there for a sec.
Sorry, I think I cut out there for a second.
Okay, great.
So this is how the anal
Sorry,
PAP
could you
pathology.
share your screen?
Huh? Oh, sorry. Oh, it's on presenter view. Okay.
And thank you, Danica, for the side-by-side support.
There we go. That, nope, that's still presenter. These never go correctly. How's that? Better? Okay. All right, so this is how the anal PAP pathology results broke down if the result was abnormal. Over half of them were ASCUS and the remainder were LSIL, and only one case of HSIL were detected on screening anal PAP. However, pathology results from the 23 patients who underwent HRA showed that 9 patients had HSIL and therefore were potentially intervenable to prevent progression to cancer, as shown in the anchor study and as we'll discuss. And those were 5 patients who had ASCUS and 4 patients with LSIL on their previous anal PAPs. So these are extremely small numbers. We don't really have the power to make any statistically significant findings, but it did seem important to note that HSIL on HRA was detected as lower grade dysplasia on screening. And so if shown at a larger scale, these patients should still be included in the cascade and referred for HRA. And then worth noting that the one patient who had HSIL on their anal PAP actually had anal cancer on HRA and biopsy. So this was detected early before the patient became symptomatic. So there are some big and fairly obvious limitations to this work. This was designed as a QI project, so it focused on a small sample size and a single clinic that was not ideally followed through the trials and tribulations of the early COVID pandemic. There's also some notable variation in provider practice and referral processes that couldn't really be controlled for, although we do have that data if anyone's interested in their own personal statistics. We also only looked at the MSM population, and the cross-referencing we needed to do to generate this demographic variable probably missed some of the patients that would have otherwise been included. And then finally, we didn't capture whether patients already had a history of anal dysplasia to see if these are potentially patients who are getting screened at a higher rate than patients who either didn't have a history or had not undergone anal pap smear before. But just to emphasize takeaway points, only a small proportion of eligible MSM patients in our clinic were able to navigate the anal dysplasia screening process from start to finish between October 2019 and April 2021. And the highest step-offs in the cascade were conducting the anal pap smear during an in-person visit and in scheduling and completing an ordered HRA referral. And that finally, we have preliminary evidence, at least, that undergoing HRA for any MSM patient with an abnormal PAP is important for the detection and intervention of high-grade lesions to help prevent anal cancer. And then some future research questions this project could potentially take, looking at why in particular patients are not undergoing anal PAPs or not completing their HA referrals, which just would likely require a deeper chart review and some qualitative work that we unfortunately didn't have IRB approval for in the original protocol. Looking at trends over time, especially uptake pre and post pandemic, and just thinking about how this cascade may work if telehealth is going to play a larger role in patient management moving forward, since anal PAPs do require in-person visits. And much of this was impacted by the evolution of how HRA referrals were done. So now that that is more standardized with the Greenspoon Clinic, we're hoping there may be a higher rate in completion overall. And then finally, looking at a similar analysis among other patient groups like women, both transgender and cisgender, which traditionally have even lower rates of screening than MSM, will be important. But that is it. We're happy to take questions.
Well, thanks so much, Chelsea. And I don't know if Joyce, you wanted to comment at all on how the clinic, or if we should move on to Dr. Buchwald and then maybe circle back to clinic things towards the end.
Yeah, I want to commend the fellows. This was a, really, I mean, it ended up being a very challenging project to complete, for the two fellows who started the project and then carrying on with, the four fellows here. It took a lot of persistence. There was a lot of back and forth with the IRB and the data trust, and then extracting the data. I mean, they really went through it the whole way. So just want to commend them. And it's really helpful, I think, for us as a clinic, for us as providers, for us, who are working on this anal PAP cascade together. Having this concrete data is really going to help us moving forward. So just lots of commending them and appreciation for their work.
Yeah, I would certainly agree. That's also interesting from our side, for Maza and myself and Bridget. I mean, it's very important to see that because we are at the back end, I think it's important. Obviously, this was a time of big transition for our services that we provide, because we just started the clinic and then were shut down because of COVID for some time. But it's important, and one of the important messages you can see is that ASCUS doesn't mean that there is nothing on HIA, right? And it still is highly, highly suspicious for something that is at least high grade or worse. So anyway, thank you very much. I think it's very helpful. Also moving everything forward and, collaboration. Also, for example, making sure that more of the patients that are referred are also ending up getting an HIA. From our part, I think we're certainly getting better with this and also have more availability and more clinic services available.
I think you're right, Ricky. It does show an important point that a lot of times on anal cytology, it's a very sensitive test, but not as specific for looking for lesions as HRA. So it was shown in this study. And then also just for myself to monitor in patients with HIV, MSM, that I'm getting close to a 50% detection rate for high-grade lesions. So I think it's good to monitor these patients. I think for some of the barriers to care or the COVID pandemic, for sure, transition between providers, even changes in the guidelines over the last couple of years that now emphasize more cytology and HRAs for any abnormalities. I think that's part of the barrier to the care, and it also makes me think about ways we can improve our make it easier for patients to schedule their HRAs. Ricky's incorporated a telemedicine program, more than a year ago. So since having telemedicine consults and a lot of education, we have a very good show rate now for going forward with HRAs. And then maybe just other things like epic reminders, or we talked last year about self-directed, anal PAPs maybe in the future for patients if there's problems with them getting into clinic to do a PAP smear with a provider. So I think it's good food for thought to how to improve our clinic for the future.
And I don't know how you want to manage the time. I'm happy to share the current referral process.
That's fine.
Is that good to do now? And then we could, I think Chelsea brought up some good next steps, or we could wait until the end of Ricky and Maza's presentation. What do you all think?
Up to you. We can, do you want to just go ahead and?
I'll just share this, and I will say that, you know, are you seeing this? Okay. Okay, so, you know, we have kits in the clinic to do the screening if it's normal. And, you know, there are, I think Ricky and Maza are going to go through the guidelines of who should be screened and how frequently, normal, typically an annual anal pap. If there are any abnormalities, we used to have a complicated algorithm for high grade versus low grade because of limited HRA, but with the Green Spring Clinic, we send everybody to Green Spring who has an abnormal anal pap. And that's done through ordering a high resolution endoscopy. And the Green Spring team, then with that referral, it goes into a queue and their team is reaching out to schedule the patients for an appointment. With the departure of Dr. Fang, Dr. Fang enlisted Chadi Atala, who's really terrific. And the Green Spring team coordinates with Dr. Atala for patients who may need some additional, you know, surgical intervention. So they will manage that on their end. And then if you're in clinic and, you know, there's something highly suspicious that, you know, may warrant a surgical consult right away, you can either refer to Dr. Atala. I've, you know, reached out to him individually. I've reached out to Ricky and to Maza and Bridget individually to consult. They're really, really excellent clinicians and, you know, very willing to talk through any questions that you may have. So this is our current sort of process for making referrals. It's in the Teams chart. It's in the Teams chat. I just put that in again, or I put it in a few months ago because there were still some questions, but that's where that is. And I don't know if people have questions about this.
I think the one thing that would be great to add to this is if you have someone who doesn't appear to have been scheduled, like who the right person to reach out to would be for patients who fall through, who the HRA referral is placed, but then not scheduled. Like, what's the best way to do that? Is there a scheduling coordinator or somebody to direct contact? And if we just add that onto the sheet, I think that would be great to have it as a reference.
Maza and Ricky, do you have recommendations? Because I believe it's your coordinator who does the outreach.
Right, Darlene Brown, we can certainly, you know, we put this on there and give you the information. Some people also directly message us and then say, hey, can you look into this? And, you know, we are then following up with Darlene, but Darlene Brown is our coordinator and, you know, is usually very good in keeping track and, you know, can explain what happened. Sometimes it's patient issues, sometimes it's scheduling issues. So,
yeah, exactly.
You know, a lot of my patients do not answer the phone. If they don't recognize the phone number, they don't answer the phone. And we're now hearing that Johns Hopkins phone numbers appear as possible spam on their mobile devices. So, you know, I'm hearing that outreach is happening from Green Spring to patients, but it's possible. And yeah, so
so Joyce, one question about that is that I always find that like having people schedule it when they sit at the PSC desk at the end of the visit, if it's an in-person visit, is sometimes very useful for things like radiology and other things where like when they haven't had it done multiple times, it's like, please don't leave until this is scheduled. Would it be possible for in real time for our PSCs to reach out to your coordinator so that they walk out with the appointment in hand, or that would just be one other possibility?
I think there may be some insurance review that happens. Ricky,
yes.
Maza, correct me if I'm wrong. I think there's an insurance review that happens before the appointment can be scheduled.
Yeah.
Yes. The majority of patients, I think, are able to get their HRA, but we've had a few patients where we've had to get prior authorization. So Darlene does have to review their insurances. And I'm going to put in the group chat. Darlene Brown is our office coordinator. It's D Brow, DBROW. I think it's 126. I'm going to put it in the chat right now at jhmi.edu. And our office phone number is 410-828-3585.
And, you know, the other option is I've sometimes reached out to navigators and or nurses to sort of like if there's somebody who's super high priority, you know, to just help ensure that the appointment is happening or help figure out what problems there might be. Any other questions about this process? And then in terms of like from a quality improvement aspect, working with the Sprint team, we've been talking about, and again, I think we'll need some feedback from providers, but there is the option to create some health maintenance topics. And, you know, just to help remind people to do an anal PAP, we can put in a request for patients who meet certain criteria that providers would get like a tickler to do an anal PAP. And, you know, you put in like the frequency with which that could occur. So, you know, when, you know, based on guidelines, you know, that sort of health maintenance topic can be created and updated. And then providers, you have the ability for your individual patients to alter that health maintenance topic for whatever reason. So that might be a way to increase the number of anal pap smears that are occurring for patients.
All right.
Yeah,
Awesome. So why don't we turn it over and you guys can give us your update from the anchor study. And I have to say my impression of the anchor study was that it was like potentially practice changing for me in terms of the strength of recommendation that I gave to my patients about their follow-up exams and the clear benefit to repeated HRAs. The one point where it felt like a lack of data to me was because I just did every HRA on everybody, I still don't feel confident that my anal PAPs are screening in all the people that I need to, or the other information we need on how to. My current approach is just to keep doing anal PAPs, hoping I'll get a funny one so that they can actually get an HRA, but I'd love to hear your much more sophisticated interpretation of the data. So thank you for coming, and please go ahead.
Can you see the screen?
It's not in, we can see if you just click the slideshow button, I think.
Okay.
At the bottom.
What am I doing?
On the right side,
Right next to the 63%.
the percentage, right?
Yeah.
I don't see it next to the what?
On the very bottom to the right, next to 63% is, click that little monitor system there. Like you have comments, then you have this icons, and the white one next to the 63%.
I don't see the 60. Are you able to do it from your email? Ricky, I don't see a 63. Let me go back.
So are you in a full screen view or are you looking at your PowerPoint?
Yeah, I'm putting it in full screen now.
Okay, it might be showing us.
Yeah, it is showing us. I think I just recently gave a talk, so I think that's how.
Anyway,
it's set up.
maybe
Try
you
that one.
just start and we can figure it out. I can also load
Okay.
mine and then take
Yeah, it moves. Yeah, I'm sorry, I can't figure it out, but my name is Maz Abdi, and Dr. Buchwald is with us. So we lead the HRA clinic, and so Joyce had asked us to give an update on anal dysplasia and cancer screening, including the anchor study, and some updates on our HRA clinic. I'll try and make it short. We do have a lot of slides in the interest of having a good discussion. So I have no disclosures. Dr. Buchwald is a section chief at Merck. And so the objectives of this talk are to review the incidence and risk factors of anal cancer, discuss screening modalities and treatment options for dysplasia, evaluate preliminary data on the ANCHOR study, review updated screening guidelines for dysplasia, and understand the role of HPV testing. So just quickly, I'm sorry, I have it in my other mode, but quickly I'd like to just go over the epidemiology of anal cancer. Unlike colorectal cancer, anal cancer is less common, and according to the American Cancer Society, there'll be...
Martha, sorry, briefly, I don't think you're advancing the slides right now.
Okay. Maybe
okay.
Joyce, can I send you, who's in charge of the presentation?
You can email me that.
Let me do it. Let me do it. I can take over and share my screen.
Okay.
And,
so let me stop my sharing.
Works, and then you just tell me to advance when you want.
Sure.
Can you guys see it in full screen?
No, I don't see it yet.
If you want to email it to me, I'm happy to.
Okay.
I have demonstrated the ability to share my screen with my device. So if you want to email it to me,
I'm going to send it to you right now.
Oh, Ricky, I think we're just starting to see your screen.
Okay.
And now, yeah, perfect. And
now you see full screen?
Yes, we do. And Maza, last week I was claiming someone else wasn't speaking because I didn't have my earphones in. So welcome to the welcome to the conference.
Okay, so we had the objectives and Maza was at the epidemiology.
Yeah, I was trying to put it in the full screen mode. I gave a talk last week, so I think I altered my PowerPoint and don't know how to alter it back. But so let me go back. See your screen. Okay. So for the I couldn't see your screen. For the epidemiology of anal cancer, unlike colorectal cancer, anal cancer is rare, and so the American Cancer Society predicts that there'll be 9,400 new cases of cancer in the United States this year. But the take-home point is that the incidence of cancer has increased by 2.7%, and especially in high-risk populations, which have a 40 to 50-fold rise. Next slide. So the risk factors for anal cancer are persisting HPV infection, history of vulvar, vaginal, and cervical cancer, anal genital warts, multiple lifetime sexual partners, receptive anal intercourse, immunosuppression, HIV, and tobacco use. And this is a meta-analysis providing comparable estimates of anal cancer among high-risk groups. And so the highest risk categories are men who have sex with men with HIV, followed by HIV positive men and women, and then anal genital diseases, so vulvar cancer having the highest risk, followed by immunosuppression, solid organ transplant, especially for more than 10 years. Next slide. And so this is the screening algorithm that we use for management of anal dysplasia. So it first starts with counseling with the patient. And so identifying at-risk groups, such as the risk factors we just talked about, MSM, HIV status, immunosuppression, women with a history of anogenital malignancy, and providing digital rectal examination, which is an important part of the examination, and anal cytology. We don't offer HPV testing for initial screening in our clinic. If anal cytology is normal, you can repeat screening every 3 years in HIV-negative patients and annually in patients living with HIV. If anal cytology has any abnormality, so low-grade changes or high-grade squamous intraepithelial lesions, they can be referred to HRA clinic for further management and treatment. So moving on to management, once you have a diagnosis of squamous intraepithelial lesion, we offer HRA with biopsy. In general, we only reserve exams under anesthesia for patients who request it or who have very extensive perianal disease. For patients who undergo HRA and biopsy and have a normal biopsy and who are HIV negative, they can be discharged from clinic and follow up with their primary care doctor. For patients who HRA with biopsy shows low-grade squamous intraepithelial lesions, in patients who are immunosuppressed or HIV positive, we will repeat HRA annually. If HRA is normal or shows persistent low-grade changes, then we will consider spacing out HRA to even every 1 year to 2 years, or going back to PAP testing. For patients who HRA with biopsy shows high-grade changes, we provide treatment options, so medical, ablative in-office, and ablative surgical procedures, including imiquimod, 5-fluorouracil for our topical treatment options, infrared coagulation for our office-based treatments, and hypercator, which is electrocautery in the operating room. Once treatment is provided, we repeat HRA at 6 months to assess for treatment response. Next slide. And so we know that early screening helps to detect cancers. And although there is not as much strong data about the natural progression from HSIL to anal cancer, there is some information through registry studies that patients who have high-grade changes do have an increased risk of cancer, maybe about 10% over a 5-year time period. So the question is, does treatment of HSIL reduce the risk of squamous cell cancers? And so an anticipated to be published study, the ANCHOR trial out of UCSF, addresses this question. So the schema for the ANCHOR study is it took HIV positive men and women over the age of 35, and they initially had a screening visit with high-resolution anoscopy, and if biopsy showed HSIL, they were enrolled into the study. They were randomized into 2 arms, active monitoring or treatment, so that patients every 6 months in both arms underwent digital anal rectal examination, high-resolution anoscopy with biopsies as needed, anal cytologies, and blood samples. For patients in the treatment arm, they underwent ablative therapies, and it could be medical or office-based treatments. And then the outcome was to see the development of cancer. If cancer was found, the patients were exited from the study and treatment was offered. And the goal was to enroll about 5,000 patients and follow them over a 5-year time period. Next slide. And so the goals for the study were, there were primary, secondary, and tertiary goals, but the main goals were to determine if treatment for HSIL decreases the incidence of anal cancer. So that's the primary aim of the study. Number 2, determine safety of treatment. So infrared coagulation, electrocautery, imiquimod, 5-FU, laser therapy for anal HSIL. Also to look at quality of life with screening and treatment for HSIL and develop an ANCHOR health-related symptom index. And lastly, collect biospecimens to look at the pathogenesis of anal cancer and HIV, specifically identifying host and viral factors in HSIL progression to cancer, host and viral biomarkers for progression from HSIL to cancer, and identifying medical history and behavioral risk factors for progression from high-grade changes to cancer. Next slide. And so I'll maybe cover this slide and then I'll have you take over, Ricky. So the results from the ANCHOR study that were presented by Dr. Poletsky at CROI this year were that a total of 10,723 people with HIV were screened between September 2014 to August 2021. More than half of the patients were found to have HSIL at study entry, and 17 were diagnosed with pre-existing anal cancer. 56% of men, 46% of women, and 63% of transgender populations were found to have HSIL. The prevalence for HSIL was what was expected for men, but it was higher than expected for women, a group that's not been screened before. And for the treatment arm and the monitoring arm, 4,446 people were randomly assigned to the treatment arm. 4,446, shy of 5,000 people were enrolled into the arms. 2,227 underwent treatment or active monitoring, and that was 2,219 people. The median age of randomized participants was 51 years of age, and they had been living with HIV for a median of 17 years. A majority of the patients were men, 80%, mostly gay or bisexual. 16% were women, 3% were transgender, and for the racial breakdown, a third were Caucasian, 42% were African American, and 16% were Latino. And more than 80% of patients were on antiretroviral therapy, had undetectable viral load, and a CD4 count that was approximately 600.
You want me to take over here?
I think I'll have you take over now.
Okay. Yeah. So I mean, obviously we don't have the full study data, right? But what was published so far, there was a 57% risk reduction in the treatment group, and that's why the study was halted early. So 9 people in the immediate treatment arm and 21 people in the active monitoring arm were diagnosed with invasive anal cancer. And I mean, what is not surprising is that, those diagnosed with anal cancer, were at an early stage. And I think this goes back a little bit, Aline, to your question, and we can discuss what this study actually, evaluated and what it didn't evaluate. It really didn't evaluate the pathway of not to screen, right? Because people were, first of all, they enrolled HSIL patients, and then they just didn't treat it. So that's really what the study evaluated. It didn't evaluate the, per se, the screening algorithm versus no screening. So you can also see some information on the type of treatment. It is our understanding that there was a transition at some point from using the infrared to electrocautery ablation, but it was generally done in the office. And you can also see that some people received, several types of treatment, which is oftentimes what we are dealing with because of the, large extent of disease or, also recurrent rate. Interesting, also not new though, but nice to see here that the smoking was, associated, it seems to be associated with anal cancer, though, it wasn't significant, and the full study analysis are pending. So this is a quotation by Dr. Palevsky, the first demonstration that screening and treatment reduces anal cancer. And, the question obviously whether this will become the standard of care for people 35 years of age and older. So some of the implications, and I think for the HIA provider, in the country, and those people that, are also treating the patients at risk, I think this can have, kind of revolutionary aspects. And one of the problems is obviously that we are facing that we need, more HIA diagnostic and treatment providers. One of the questions that, Dr. Palevsky and also, the International Anal Neoplasia Society have been discussing is, what is the appropriate accreditation and the standards for, for training. And then on the more scientific side, there is this, this somehow unresolved question, obviously, on what the appropriate treatment is. We know that, this treatment is successful in addressing the progression to cancer, but it's also not really kind of fulfilling for the patients or the providers because we can't eradicate the HPV. And so, there's a relative high recurrence rate of, HSIL and HPV associated lesions. The screening algorithm is also something that still needs to be better, I think, identified. And I just also briefly, tell you about what we are doing now with the HPV testing. But definitely, we know that overall the risk of progression to anal cancer is not, is not as high as, for example, for cervical cancer, for CIN3, to cervical cancer. But we don't have, good biomarkers beyond maybe the cytology, and the biopsies to see, who's at risk for progression. And then, obviously the discussions around what do we do with the standard of care guidelines and cost benefit analysis, that is all pending. Obviously this is a huge field for investigation. When you think about other cancer screening programs, we are still debating, breast cancer and prostate cancer screening, and those have been implemented for many, many years. So I just also, we don't need to go much into details of this, but I also wanted to highlight that, you know, there's an updated screening for anal dysplasia and cancer in adults with HIV from the New York State Department of Health. Just also highlighting the age cutoff of 35 years of age. That was what the ANCHOR study did. I think that many of you are probably not, thinking that strictly about the age cutoff. And I don't also know, whether we should introduce it. We often see younger patients also with significant disease. Yes, they may not have anal cancer yet. So I think it's a little bit something that we can also discuss, whether we should introduce that age cutoff. Sometimes I also find that it's an opportunity just to educate about anal health, about STD prevention, about HPV vaccination, and just open the communication between the patient and us a little bit on, what they can do for sexual health and anal health. The other big topic is actually here, and I don't know right now whether it's here, but really what these guidelines also point out, don't forget the women. I think that is one observation that we also make, that we actually don't see as many women as we see men, right? Actually, in our clinic, we also see a significant proportion of people who are not living with HIV, because we have a lot of referrals, for example, from Maza's colleague on the gastroenterology side, that now increasingly are aware of colonoscopies with abnormal anal findings and then refer to us. But I think even from the population of, the Bartlett clinic and people living with HIV, we don't see enough women. And I think that seems to be also one of the messages from ANCHOR, that the women were, kind of underrepresented, as you can see, but then, kind of maybe had more disease and, because they were not as regularly screened. I think this is just all, on the follow-up. And so let me briefly go to the HPV testing. Obviously, you are familiar with this on the cervical cancer screening side, and how it really changed also the approach to cervical cancer screening. So in the anal cancer screening field, it's a little bit more tricky, especially when we are talking about people living with HIV, because oftentimes, we find a lot of HPV disease or HPV, not disease, HPV types, and HPV infection is very high, and oftentimes there's also several types. So the question is, how can it help us with the screening, right? But you can see here also, that there are some studies that suggest, that the value of the cytology screening is actually improved, especially with regard to the negative predictive value, if you don't find any HPV 16, 18, or other high-risk HPV. So it is still kind of investigational, and it hasn't really made it into, kind of the screening algorithms, kind of as officially as we somehow have, for the anal cytology, even though that, as you know, is not really well standardized. Here, I put down, a study that was recently published, even though it was a small study, that also looked at different testing. And you can see the COBAs together with cytology, which is actually what we do, what we have now also available at Hopkins. There is an improvement of the sensitivity, and then, you have a relatively high negative predictive value for the combination of cytology and HPV screening. So this one is also from the New York State guidelines, how you incorporate the HPV testing into the anal cytology screening. And you can see here, where under the reflex testing, HPV negative, that you go to annual cytology. So let me tell you, what happened at Hopkins here. So we've been working with our microbiology lab. Actually, it ended up being over a year because they were so busy with COVID testing, but they were very, supportive of validating the HPV testing with the Roche assay, the COBAS, for anal specimens as well. And, they completed that at the end of last year. And now, we have the ability to do actually co-testing as well as sort of reflexive testing on anal pap smears. So when we had started to do this within our clinic earlier this year, and we also were not very sure whether the insurance companies would pay for it. And then we started also to monitoring that the payments and what the patient copay would be, because we don't obviously want to overburden our patients with costs that they may not be able to handle. So far, our experience actually has been quite positive. We didn't hear any complaints from patients. We usually tell them that we tested and that they may have a little bit of a copay of like $10 to $14 for this. And we are starting to kind of get our experience with the HPV testing and test results. So we are not truly following this algorithm, because this algorithm would be at your level, right? That really where you make determinations whether you would refer to the HRA or not. What we are using it for is actually a little bit different at this point, and it's not really that we follow an algorithm. It's more like the gestalt for each patient. For example, those that have LCL lesions but that are high risk HPV positive, right? Like HPV 16, HPV 18, or other high risk HPV types, which is the readout for our test. I would consider then, well, this is an LCL, so it might not, have the same risk of progression, but still it's high risk positive, right? High risk HPV positive. So I may want to see this person, back earlier than, for example, somebody who's LCL and high risk HPV negative, right? So that is, where we are getting, the first experience with this really just for a couple of months now. And, we can certainly also work with you to figure out, whether and how you would like to use the HPV testing, at the initial screening side. But we have to be aware that, the data are, limited and more limited, than for the cytology in terms of, screening algorithms. I also don't know yet entirely whether just from the swab performance, right, whether there is any variability like that you can just miss, the HPV types. I didn't get a good feeling for that yet, but it's done basically on the same swab that you put for the anal cytology screening. And then, as said, you can either ask for it at the same time or reflexive if you would have an abnormal anal cytology. And this just summarizes some of the, the approaches to anal cancer prevention, with the primary prevention, secondary and tertiary preventive approaches and interventions as discussed. So our other updates from us, so I think we have actually by now like over 300 patients that we saw. We really have a very good show rate. We see diverse populations, living also with other immunocompromising conditions. We have seen a couple of women actually that have, like rheumatoid arthritis or SLE, or, in the past, some psoriasis and immunosuppressive therapy, and they are in their 60s and they have actually high-grade dysplasia. And we had one woman, who had actually metastatic anal cancer. So we are now expanding the clinics, and I think we will eventually, after July, offer up to 6 HRA clinics per month. As Maza mentioned, we have the teleconsult. Usually it's appreciated, and we think that it helps our show rates because people are aware of the procedure, and they know what we look like, and as mentioned, we do the infrared coagulation in the office and also work closely with surgery. We have a couple of research projects. One is the survey of the anal dysplasia screening practice in transplant populations. I think Eileen also mentioned that we don't have, or one of the fellows, I think we don't have, the best approach. Christine Durant, I don't know whether Christine is on the call. Actually, I can't see the participants right now. I was referring, on a regular basis, but outside of, the HIV transplant population, we don't have a comprehensive approach yet. And MASA has a project to look at other biomarkers such as DNA methylation for cancer screening. And as mentioned, we are trying to gather some experience with the HPV testing. Okay. I also want to and I'm happy to send those out, for distribution. There's another summary, actually in the clinical infectious diseases a couple of months ago, also by Joel Palevsky, that, starts to address some of the main, questions for anal cancer screening, based also on the anchor results. So I'm happy to share that. Yeah, thank you for the invitation, and we probably have a little bit time for discussion.
Thank you both so much. That was amazing. And I had collected a few questions in advance. So just a couple of things. So first, I'd like to ask, what is your practice and your recommendation about HPV vaccination? I know obviously the role in the setting of potentially already identified dysplasia is very unclear, but I also wonder about how with the under 35 and hopefully many younger patients will be getting vaccination, like how we'll think about those guidelines. I noticed that the guidelines currently say regardless of HPV vaccination status, but how does that feed into your decision making, and have you tried to get the vaccine for people who are otherwise don't qualify based on age or other, basically age?
I mean, currently we're recommending vaccination for patients from the age of 12. The guidelines are 12 to 26, but it can be expanded to 45. So for our clinic, we anyone who's under the age of 45 or under, we recommend vaccination. So we strongly encourage. I mean, there's especially for patients with HIV, there's not only do they have trouble with increased replication, problems with clearance, but also multiple infection with multiple subtypes. And even on just the limited 3-month data that we have on HPV subtyping, we have many patients who have 16, 18, or non-16, 18. So there's multiple subtypes that you can acquire over your life. So we encourage vaccination for everyone up to the age of 45. And you can start as early as 9. I mean, we don't see pediatric patients.
I was thinking we could maybe add that into our health maintenance with the anal PAP, because I don't think that's one that we're prompted to give. And I know I have a PrEP patient who is like extremely savvy, who got himself through his insurance, even though he wasn't in necessarily the right age category. But insurance can be a barrier, but it would be great, because I don't think I'm doing a great job on that front.
Yeah, and insurance is problematic. So, while it's FDA approved up to 45, people who don't meet the specific guideline, there are payers who don't pay. And so I have the pharmacy call the insurance to run it and see if it's covered. And, I have some patients who it hasn't been covered. And it's, it's like hundreds of dollars per vaccination. So the insurance is definitely a barrier.
Oh, that is sad to hear. So let me tell a little bit from my perspective, and with the disclosure that I work for Merck, who's manufacturing the HPV vaccine on the market in the United States. But yeah, I agree. With said, I mean, it is possible to give up to 45. I think that the ACIP recommendation make it a little bit difficult, because you have that patient-provider discussions, and then also I think they have a note in there on immunocompromised, right? I mean, this is the crux we are facing with every vaccination. Those that need it most because they are most vulnerable, usually they don't have the best functioning immune systems. And I think that it's still, it's difficult to measure, but, overall, at least, the data that are available for mid-adult vaccination actually suggests that there is, a good immune response, and then also, it is still effective, even though, yes, everybody should be vaccinated. Obviously, when there are, children now that, or, like adolescents now that it's available. To your question, I don't think we have any, we don't have any evidence or impact on those that are vaccinated yet. Yes, eventually it will probably shift our practice in terms of screening, but I don't think we are there yet at all. The uptake of the HPV vaccine in the United States is suboptimal. It is specifically, not good in men. It is, in our vulnerable populations, I think, we are not there that we could think in, population health-wise, there's less transmission and, we can reduce screening. So I don't think we are there.
And then other questions that had come in prior were anal paps on HIV positive men who deny any sexual activity with other men, and then also by extension to women, and how, as we think about Joyce's excellent suggestion to build a health maintenance, should this be for everyone or should it be only for specific populations at risk?
So I think you can see here, that's why I'm pulling up the slide, right? You can see here that, the non-MSM, for example, males with HIV, right? This is still a relatively high incidence, right? As compared to also, HIV uninfected people. The same is unfortunately true for, for women, and you can see HIV positive women, especially when they're above 45, are approximately similar than males non-MSM. So I think that there is a significant burden of disease that we are just not recognizing. I think that would be better to screen patients once. From my perspective, seeing a lot of patients, it's always like that I would also not be opposed to have a screening algorithm that is HRA for everybody, which some centers like Mount Sinai in New York have done for some time. It is a bottleneck issue. It's a provider issue, right? Because we don't have the capacity. That's why the screening, the ASCOs and stuff, that is a little bit of a triage because we don't have all the availability. When we see patients, usually you get somehow an idea that there is disease or there's no disease. And, there are those patients that have a significant burden of disease. And, you recognize that when you do an exam and you do the HRA, and then, you can follow them up. If there's no disease, we also, we don't over-screen them. They don't have to come back every year. Maybe with the HPV testing, we actually have an NPV then that is even better and allows us to phase them out of the screen, right? But I think that a priori, this is not, we shouldn't, discount the significantly elevated risk in those populations. And similar, what mentioned, not so applicable for your care here, but we see these patients here too, right, on the right side, non-HIV immunosuppressed. They have an elevated risk, and I think it's now, especially with the ANCHOR results, where we know that treatment does something. If we can identify HSIL, we should.
Well, and then I know we're a little bit after the hour. We've got great retention because everyone's staying because this is so useful, but I should be mindful of the time. The last question was just actually a very big thank you to your team. It has really transformed our ability to provide high resolution anoscopy care in a way that I am so thankful personally that the process of referring people in the past has been so cumbersome and so challenging to get through. We are so thankful for the excellent care of our patients and for your team's availability to us all the time. So thank you so much for coming. And you may get some other follow-up questions over email. We'll try to post these slides to the team so that people can see them, and also that additional referral information in case anyone needs to follow up on someone who's fallen through the cracks, whether that's patient side or other side. And we'll stay tuned to hear what to do as the data evolves. So thank you so much.
Yeah, thank you very much for the invitation. I appreciate that. And I think there are a couple of topics where we can also, work together, identifying better pathways. And I think this HPV testing is one of the topics that I would be interested to work with some of you to figure out, does it actually make sense, starting that on your end, right? And how would we approach this? Not that you guys are overwhelmed with data, but that it also is meaningful in the decision making. So I think that is something where we can, Joyce, we can start working together now that we're collecting some experience on how to do that from our side. And then anyway, always just email us with questions or concerns or anything else.
All right, thanks everybody.
Thank you.
Okay,
Thank you. Thank you, Maza. Take care.
Okay,
Great
thank you.
work. Great work, everybody.